coming. We've got a smaller group, so it'll be an informal session, but we want to make it interactive. We want to, we've talking about the alternative voices, and I really love the rare disease thing, and you talked about social media, and we're going to continue some of those themes here.
Okay,
so
cool.
it's a really nice segue. In front and center in our thing, we've got this hashtag #MedXDog. So if anybody's interested in tweeting, you can tweet the conversation.
I love you.
And if there's questions that you have that we don't answer during the presentation, because these things are kind of 40 minutes and they're short, or if you want to continue the conversation, please use the hashtag so we can follow along.
And the medics one as well, otherwise we'll get lost.
Yeah.
Oh, yeah.
And plus, we need to make everyone jealous who's not in this room.
Exactly.
Thank you for that. Yes.
So there's a smaller group here. Do you guys, anybody have dogs at home?
I do.
Anybody have service dogs? I know you've had kids with...
Yeah, we have kids with dogs, but we work with, the foundation I have in Las Vegas works with a lot of rare kids, and that's like the new thing now is trying to get service dog, because a lot of kids have seizures and epilepsy and other issues that service dogs could definitely help with their quality of life. So I'm actually really glad this was right after.
Perfect. That was
where we're
such a good
leading
segue
to.
for us. And so we're going to spend the next 40 minutes or so talking about some experiences with animal-assisted therapy. I am not the expert on that. My name is Susan Eller. I'm an assistant dean here for immersive and simulation-based learning. I kind of get dragged in because I think this is awesome. But I want to let the team kind of introduce themselves to you so you kind of understand the genesis of how this came together.
Okay. Hi. Thanks everyone so much for being here. I'm Alexandra Winter, and I'm a veterinarian, actually a horse surgeon, and a journal editor, and we're really thrilled to be here today. I actually brought this together, and I'm so happy to have my friends and colleagues here. As we go on, I'll talk a little bit more about why we did this, but everyone else can introduce themselves.
I'm the other Alexandra. To make it easy, I go by Lexi. My background is anesthesiology, so I did my training in Australia. It's actually just a coincidence that we're both Australian. And both called Alexandra.
You can only be part of it in this case, sorry.
And I also have a background in education, so I work as the Director of Simulation and Education with Susan, and actually our simulation centre is just on the basement level of this building.
Oh, very cool.
And I'm Natalie Abbott, and I was drafted here by Alexandra. She saw a dog last MedX, and...
No, I didn't. I saw you both.
Okay.
And the horse.
Yes. But I've had practice for 4 years, but before that, I had a lot of experiences, as we're going to see, with anesthesia as a young child. So I'm very interested in this subject.
Did you introduce yourself? Oh, I did. Yeah.
Good. Basically, when I was at Medicine X last year in September, I was really struck by so many of the e-patients in particular. They talked about the role of animals and so on, and it's something anyway that I think sort of we see a lot about it, but I don't think there's a lot of education and real sort of discussion about how to implement this. And so I'd come across, I'll talk a little bit more about a case report that I was aware of and so on. So I felt just compelled to try, and particularly in this setting, which is such a great group of people, and talking about how to implement patient-centered care. And so that's why I wanted to do this. So that was the genesis of it. And then now Natalie is going to speak a little bit about definitions of service animals and so on.
Okay, so this slide is actually the first known mobility service dog. Actually, ironically, not coincidentally, from the organization I got Cassis from the 1970s. And so it's come a long way. It was first guide dogs for like 50 years, and now mobility, and now autism and seizures. And okay, so kind of polling the audience, does anyone have a short definition of what they think an assistance dog is? Or long?
Assisting with activities of daily living, and like, I don't know how you say medical protection, but
yeah, I know that some of our families, because our kiddos have seizures, and so their dogs can sense seizures coming on and alerts the the caregiver of the disorder or the person having one.
And also PTSD. I know a lot of our military. We have a neighbor who has a service dog. That was what he was granted on for.
This is one conversation where I'm typical. Everybody sees guide dog and they think blind, and I represent the blind community, and there's so many other
That's right, because I don't even think of blind anymore. I go straight to the quality of life.
Like the
you blind old
news.
people.
Yeah, we're the old news.
So old, Patsy. Sorry.
Yeah, Natalie, misconceptions, in terms of those, I think any misconceptions you wanted to just mention about people's not understanding service dogs?
No misconceptions. Just as we say, there are a lot of therapy animals out there, and any animal can be a therapy animal if you go through the right channels. But only dogs and select miniature horses can be technical ADA service animals.
Really?
Yeah.
I didn't know that.
Yeah. Important.
I did not know that.
So in court, only dogs and miniature horses.
The miniature horses are cute.
We're very cute. I don't know if they want one, but they're really cute. And I mean, this slide is pretty self-explanatory. As we know, all dogs provide some inherent benefits, but service dogs have been specifically what they call task trained to help with a disability of all kinds.
I think you brought up some good points about the seizures and about the PTSD and the blind dogs. There's dogs that detect hypoglycemia based on the smell too. So I think there's just such a variety of, it's like fascinating when you start reading this. Guys were sending me this stuff and I'm like, oh, I gotta read that. So I think there's a lot of uses that, are not really well known to the general public. And I worked in the emergency department for several years. So, I saw some of the seizure dogs and some of the, blind dogs and other things like that. So it's like, I didn't know they could do hypoglycemia too. So it's been a very educational experience for me too. Since we kind of have our definitions set and we know a little bit about the, what the service animals are, and thank you for clarifying it's only dogs and miniature horses, we want to talk a little about some case studies about kind of like the case especially that triggered Alexandra's interest in presenting, because I think it's really fascinating what the use of this animal-assisted therapy and how it can create patient-centered care.
Yeah, thank you. So yes, what I wanted to talk about is we're going to sort of focus in the discussion a little bit, because obviously we could talk very broadly, but we're going to talk about service animals for children in the perioperative setting, specifically in their role in anesthesia, and this for me was prompted by a case report in the journal Anesthesia and Analgesia, which was this young girl, Ashley, and her service dog, Finn. And Ashley has autism and POTS, which is postural orthostatic tachycardia syndrome, and she was undergoing an endoscopic procedure. These are photos of her. And actually, I know the authors of the report because they were friends with someone, and this came out a couple of years ago. And these are quotes that basically what happened is that when she was having the propofol, which is the induction drug, injected, she started to freak out. And so Ron Littman, who was one of the providing anesthesiologists, stopped and asked her if she would be okay if her dog would push the drug. And then she was. And as you can see, I mean, this is a beautiful picture.
Yes.
It's extraordinary. I mean, there's really nothing like it. And that case happened, and then afterwards, one of his colleagues, Alan Schwartz, they thought they would write this up for publication, and they really focused it on the fact that it required this cooperation to provide family-centered care, where everything was done in the best interests of the patient. Just flip back one time to the previous one, and see what you'll see. And you can see she's in the OR suite, and everyone is there. I mean, it really involved everyone. And we can just go forward again. Thanks, Susan, to the next one. Okay. So this was written up, as this lovely case report. And one of the things that Ron Littman said, you know, he said, I had no problem with the request because I love dogs and I'm a former child myself.
That's a great quote.
You know, and it's like, this was from, you know, from 2013, but since the time of that report, I've shared that with a number of people because it was featured on the front of the journal, and there's really nothing else in the entire medical literature like this, where it was the dog was integrally involved in the anesthesia care for the child. And I had spoken with them back a couple of years ago when I was writing an article, and then I spoke with them in preparation for this, and I think that it was very special, you know, what they had done to provide the care for this young girl. So, you know, as I went forward and I wanted to sort of look at it and I was putting this together, I felt like it was something that we could build a story around, particularly because, as we will share, this was not a one-off case. They have gone on from that to try and develop this as an intervention that could benefit certain children. So that's sort of the background. I just think that it's, you know, in the armamentarium of things that you can offer as part of the, you know, optimal care, this is something where there really hasn't been anything. So that's the background. And we were happy to share this article, and there was an accompanying editorial too. We have that if anyone would like to read it.
And I think I sent it out on Twitter already too, so in case you want to get on Twitter.
Medics dogs, right?
Yeah. Yeah.
Okay. And this is not just an isolated case. It's happened in other things. And one of the reasons it's great that Lexi's here is because she's had experience in the OR with some of these children, so she can talk to you kind of a little bit better about, like I said, I'm an ED nurse, but she can talk to you about some of the experiences she's had in the OR without service dogs.
Yes. Which we just, sorry, before you go ahead, which Natalie also could speak to, as she did as a patient where growing up, she had multiple procedures and she did not have a service dog. So go ahead.
So the alternative is no service dog, and that has been the entirety of my experience, because I've never actually seen a service dog be used to calm a child on induction. But I'll tell you what the norm was where I worked, and then the next interesting point was to learn from talking to these authors about how the norm varies between my training in Australia and then here and even within the US. So in my experience, if we had a child like this who had severe autism, if you can't interact with them and find some way to distract them, you're taking them into this really unfamiliar environment. And they can become quite agitated. Where I'm from, we always used to take the parents in, and we would use any tricks that we could find, but generally, almost exclusively, it would involve using some drug, so pharmacological sedation, because we wanted to keep the children as calm as possible. And sometimes that worked and it was a relatively painless experience for everyone, but sometimes it didn't. And so it might have meant redosing with a second drug. So I can vividly remember cases where we've been trying to coax a 6-year-old autistic boy to drink a little bit of ketamine, another drug to use to sedate, in a tiny bit of apple juice. So convincing them to do that and then waiting until, you know, they go from running around and interacting to kind of falling over, and you literally catch them just before they're so sedated that they can't stand up, and you put them down and they still get a bit stressed, and then you get them off to sleep as quickly as possible. It's lucky when you can do that. In other cases, you can't convince them to take a medicine orally, which means the only other options are to grab them and hold them down and either put a mask with gas to put them off to sleep, sometimes an injection into a muscle. And you can imagine how traumatic those things are for the child, but not only for the child, for the parent, for the healthcare workers. You know, nobody likes to see a child in distress like that. So that kind of sets the picture for what it looks like when it doesn't go perfectly well.
But you explained that perfectly, because I'm a mother of a child with autism.
Oh, really?
Who has gone through every single thing.
Oh,
and,
really?
And, yeah, because he has seizures, and to do the or an MRI or an EEG, they don't like to sedate him, but if to get an EEG, you've got to do something to keep him still, to keep him from, you know, ripping. That was a good description.
Right.
Very good depiction.
Yeah, and we'll talk a little bit about the different sorts of environments that we might need to do this in. I mean, the two examples we're talking about are actually in an OR, and also the first one was in a procedure room, a gastrointestinal procedure room, and there are slight differences between those areas as well, so we get to discuss that a bit more. But do you have anything else to add from your experiences, or?
I don't think so.
You don't have a lot of memory from your...
No, apparently I was very, very traumatized. It took me years to get over it.
Yeah, so that's part of the problem, which speaks to this next case too. You want me to?
So you want to?
Yeah. Oh, go back to the slide. Sorry.
Okay, there we go.
Perfect.
So then, that I think that's really helpful to let. And thank you for sharing that, which sounds very distressing. So this little girl is now another patient treated by the team at Children's Hospital of Pennsylvania, and this one is really sort of feeds into this experience that Lexi has shared and that you have shared too. This is Addie, who has her service dog Data, and she has a complex medical history. She also has autism, and the important thing here is that she had undergone multiple prior procedures which had been very traumatizing, as related by her mom and then also her. So then her mom emailed Dr. Schwartz because she was going to undergo another procedure, and this is a direct verbatim from her blog where she's related the thing, and she said, "I'm not joking, the guy emailed me within 5 minutes," which this was notable. And as part of the discussion, he explained that he believed in a patient and family-centered approach. And here you'll note he's very importantly consulting with Data on the procedure. It's an important part of the care delivery, so you've got to acknowledge all members of the team. And beautiful photos, obviously. She noted he does look a lot like Steven Spielberg, and she felt that this would be a good movie, which I would agree. He's a very, very nice person, just lovely. We should do this next year and bring him here. And so, but what I loved also was some of the descriptions about, these were again her descriptions of sailing down the hallway, smiling. She swore that he, meaning Data, was smiling back. But I loved the fact, considering she'd also described how traumatizing it had been in the past, that prompted her to contact. But it was like she waved like she was on a float, which it's hard to not feel touched by that. But it's not just it's really meaningful, because when you have a child that's already has all these things you have to deal with, and then it's really important where someone really puts the needs of the child, and it's always going to be difficult. I mean, they're having a procedure, but I think this is important. So he didn't just pretend. So there she is after the procedure recovering, and this is again what she said, and he let Data stay with her, and that's exactly, we'll talk a little bit more about how specifically it was implemented. And so it's such that, the service dog is with the child until they're under anesthesia, and then when they wake up and the service dog is there. And so in that way, it's really, really making a difference in terms of for the child, but also for the parent. And he said to me yesterday in an email that, the parent has really been a good advocate, and then he said, Addie and Data are a really good team because they continue he continues to care for her. So, I think it's just a good example, and we'll talk about logistics, but the pictures tell the story.
Because you all went, all at the same time. It's so beautiful. Yeah, you couldn't have rehearsed that any better. So before we get into kind of like the logistical challenges that Dr. Schwartz, you guys you've lived this experience, right? So you know this way better. What can you imagine, and we don't want to dwell on it, but what can you imagine might be the barriers to implementation? We've put a couple suggestions up here, but what are your thoughts?
Infection.
I was thinking about sterilization.
Right. Other patients and they're not wanting
Allergies. Allergies is a good
and a degree of unpredictability as well in the situation, because the animal is also facing a lot of new things in the environment.
Right. I'll tell you my story for 20 seconds because I don't want to get off on this, but I worked in the ED, so I didn't know that thing about the dogs and the horses, and we had someone bring in a parrot.
No.
And they said it was a therapy dog, and the parrot was
Therapy
parrot. Squawking beyond belief. We had to put it in a private room. The parrot was pooping all over the
Oh.
First of all, I'm terrified of birds, so this was not therapy for me. But he was squawking, he was scaring everybody else in the environment, all the other people in the ER. And now talking to veterinarians, I learned that the bird was probably distressed too, because that's why he was pooping all over the floor and squawking.
And I'm not a bird veterinarian, but I still know it was distressed.
So again, it's like, so your predictability and these service animals need to be the type that have been trained, as Natalie said earlier,
Exactly.
to the cues and to the behaviors, and to, very responsive, that you can have in this environment very reliably.
Yeah, and that's something that's important. Should we obviously we could speak to that piece in terms of the infection, so are we doing that now or not?
I think you're talking about that later, right? Somebody
I
is.
thought we missed one in between. Was that
Oh,
one?
we missed
No. Yeah, that was it. One back.
Oh, that we don't.
Sorry, got it. So we talked a little bit about some of the environmental issues, the sterility, and a little bit about the animal. We should also spend just a few moments talking about what in the system might be a barrier to implementing this. And this is probably a question that's maybe better answered by somebody who's worked in the healthcare system. And if there's not anyone here who has, then
you'd have to get it approved. There'd be a ton of paperwork because,
right?
Like it's not the anesthesiologist who'd have to approve it. It would be the anesthesiologist, the person in charge of the whole operating room, and then probably an administrator and a lawyer at some point. I'm sure. The hospital has
Risk
liability
management,
for-
infection control.
So like, I'm sure anesthesiologists have wanted to do this in the past and just been prevented by just impossibility, honestly.
That was a beautiful summary of all the levels.
You mean there are a few people involved? And I can say that's actually, I come from England, and so not here, not from this medical system, but it's similar. And although the intention has been actually there and everybody recognizes the benefits, but the actual logistics of getting it into practice, I think people tend to give up even before that becomes a reality.
Right. That's a great point. And my training was all in Australia, and I've noticed a stark difference of even the number of service animals here, and just animals in general, the assistance animals as well. Sorry, therapy animals, and now oh my gosh.
We're going to be corrected.
Support animals, yes, the other ones that you can take everywhere.
Birds in the air, exactly.
So you're right, it's a great point. If you're paving a new pathway, it's really difficult. But actually, the example that we gave, the first one from the Children's Hospital of Philadelphia, it was the first instance at their hospital where they had used a service animal in that sort of way. And we'll talk a little bit about
because we talked
specifically. Yeah. But it benefits the patient. So why should it be so hard, like they were talking this morning on the panel? And I think this is a thing we'll keep coming back to. So how can you strike the right balance between these things that are important, like the sterility, the flow of the work, and all these other aspects that we've talked about, with what's really best for the patient? Because if you can calm down a child with a service animal, and that prevents you from giving them potentially really large doses of sedative drugs that have inherent side effects, then that sounds to me like it's in the best interest of the patient.
So the question is, how did Dr. Schwartz, who's done this now multiple times, do it?
Yeah, it's because one thing that was an important thing was to determine, one case is fine that has this just been sort of a one-off that was a complete disaster or whatever. So we had extensive conversations. As I say, it's like I spoke with him back when the report came out, and then I spent 5 hours on the plane talking to him and so on. And a couple of things. First thing is that original young girl, the nurses and everything were happy, but then afterwards they had misgivings related to sterility. So we'll talk a little bit more, but what that resulted in is some changes. But subsequent to that, he has done about 10 patients. And those have been cases that have ranged in acuity and so on. But one of the most important things, because you'll notice we had a couple of photos just back there, another young girl that we didn't speak about, and that was one of that little girl was treated at Duke by a prior fellow, but they've only done that one patient. And one of the things that Dr. Schwartz said is you have to be passionate about it, and you've really got to champion it, because as you've noted, it's not like you just show up one day and be like, yes, we're going to do this. He has been very passionate about it and really championed it in terms of talking to everyone. And you know, he listed everyone, and we can elaborate on this. And so I think that's, you know, and having been, obviously I work in a different kind of, you know, I treat horses, but it's a certain personality. If you're going to do something which people are going to roll their eyes at you or give you the side eye, as we say, and there's a lot of red tape, you have to be passionate and you have to go about things in that way. Obviously, when you're doing something that can be justified, you can't be doing something reckless. But he emphasised again and again that the need to communicate, the need to prepare for things, you know, and with the effort taking place beforehand. And he's done that. And the other little thing I would note that some people may realise is that this is not someone that just finished their internship, you know, yesterday. So there's a certain thing that comes, no offence to that, but with seniority. So clearly he may have been more effective than someone who had just finished their fellowship. But he did say that he is training a more junior faculty member to continue with this. But you know, I don't want to ignore that little piece, because I think that anyone that's worked in medicine and in academia understands politics involved and so on. So Lexi and Susan, why don't you add to that?
Well, I just keep going back to what you said so beautifully about, I can't remember exactly your words, but it was like, it's so hard that you don't even want to start.
Yes.
Stop before you even get going. And I think, you know, most healthcare workers got into that job because they wanted to do the best for the patients. And then you get into this system and it's really hard to do the best by patients. And it was kind of really lovely to hear Dr. Schwartz speak, because it really was a labour of love.
Oh yeah, it comes through. Yeah.
And part of me thinks, gosh, I hope you only choose one or two of those in your career, because that must be exhausting, because there are so many other things you're doing. But he just kept coming back to this idea that you have to do what's right for the patient. And what's more important? Is it more important to keep the workflow going, to lose 20 minutes of time, or is it more important to have this child come in and be calm and not be traumatized by the event? And a lot of time it is the workflow pressure, which I kind of sort of touched on, but not really. I mean, time is money in those operating rooms. They need to churn through the patients. And it's also productivity. You know, there are a lot of patients who are waiting to have their operations. And I think I spoke a little bit about how it's different from my experience in Australia compared to here, and even different within the US. So in Australia, it's very standard for the parents to come in with the patients. And when we were talking to Dr. Schwartz, something he said made me think, oh, it's not standard for parents to come in. And he said, no, it's actually not. I usually get them to come in, but that's not how everyone does it. And the reasons behind that are, well, if you bring someone in, then you need another staff member. You need
have the nurse liaison, yeah.
And they have actually a dedicated person who's a mummy and daddy nurse, is that what it's called?
Yeah.
Something like that. Something like that, who is there and can take the parent out once the child is drifting off to sleep. In the system I worked in, because it was standard, we just always had somebody who would take in that role, and it was usually, you know, it could be the circulating nurse who was in there to help with the operation. Sometimes it was the surgeon who took them out, because our system was just, it was assumed, and we were always set up for that. But if the system's not set up for that, then actually what you think is a really small change can actually have quite a large impact in terms of slowing down the day. And so that was kind of really interesting for me to hear.
Yeah, because I think it's an interesting thing too, because, and this is just a small thing which is completely subjective, but I think that there's a certain small attraction in trying to do an intervention that involves dogs, because repeatedly they say, well, I love dogs, you know, I grew up with dogs, and so it's like, and as a veterinarian, it always strikes me whenever there's any article in the New York Times to do with animals, there's like 5 million comments saying how, you know what I mean? So it's like, obviously there are certainly people that are allergic. I'm not, because believe me, it's like I'm not some rabbit-like animals everywhere. But you know, they did come back to that and be like, I think that there are many of them that have this vested interest in them. it's something they enjoy, and they obviously, the paramount is putting the patient first. But I mean, even the fellow at Duke, he mentioned, he said that when he was growing up, he had a golden retriever, and he would go into hospitals with his dog. So I think there's this little thread that will carry through, that they want to try and do this, because I mean, it's nice to go into work and take care of your patients, and also as a side effect, so.
Well, and I think, as Natalie said earlier, dogs are therapeutic to almost everybody.
Right? See what well, and it's really interesting, because when I submitted the abstract for here, I did actually cite a report by the Human and Animal Bond Research Institute that looked at the impact of animals on healthcare workers. And it actually showed, this was a general thing, that in general there is a positive effect emotionally for the animals and healthcare workers, because obviously it's very stressful for us, so it's maybe a little side effect, that maybe it helps your day.
I don't even know if it's a side effect, because at Stanford Hospital, they actually have a program, it's called Cuddles for Caregivers. So the pause is for the patient, and so they bring the dogs around to the patients, but they also have a Cuddles for Caregivers where they have separate sessions that are just for the caregivers, where they can go and pet the dog.
So, I love that.
Yeah.
So I mean, that's just a little aside, you know what I mean?
Who pays for the
so
dogs?
stressful.
What's that?
Who's responsible for maintaining or
They have
paying for the dog?
So the pause, they have a separate group that does it. It's actually a patient, it's sponsored. The Cuddles for Caregivers is like a volunteer group that does it, and they bring the dogs are all trained, and so maybe some of them are former service dogs, they're whatever, and they come in, and it's just
kind of like the dogs in the airports with the volunteers.
Yeah, exactly. Yeah. So I mean, so I just feel like there's maybe a little part of that going on too, just in a stressful environment,
But it's not just the dogs, and we'll talk about what else do you need for instigating the change?
So, do you want to?
Yeah, so Alexandra kind of alluded to some of the changes that were made that Dr. Schwartz walked us through. He said, everyone was kind of on board with it at the beginning when I talked to them, and then we went through with it, and all of a sudden there were these concerns raised about sterility. So they really had to brainstorm to, not give up on the idea altogether, but, well, how can we still achieve what we want to achieve and do it within the constraints of this system? And I think I mentioned before that they ended up actually putting the child, inducing the anesthesia in a room that was about 100 yards away from where the operating room was. So they'd drift off to sleep, and the parent and the dog would be taken away, and then they'd wheel the child down the hallway. And that's a pretty reasonable compromise. In fact, in some facilities, it's not uncommon to anaesthetize somebody a short distance away from an operating room. So that was the way that they found. But he said, you've got to just keep persisting. If these barriers come up, you've got to work to find an alternative solution. And that's why we have the how might we versus the we can't. And the other neat thing that came out of me asking if there was any resistance from upper level management, to speak.
My question was, how did he do it on such a short time frame? Because I'm sure the patient mother didn't say 6 months in advance or something, and because just from my own personal experience, for me to be able to just shadow a doctor took me 3 months of bureaucratic emailing. Yeah. That being said, I wasn't in the state that it might have been easier if I could physically go there. That might have sped it up slightly, but it was a lot of work, and I literally touched nothing, the floor with my shoes. And that's it.
Can I ask what that's what I'm
just shadowing.
No, I mean, what do you do?
Oh, I'm a student.
Okay.
Yeah, I'm a pre-med student, and so I just wanted to shadow in the hospital, see what I was getting myself into, right? Yeah. And it was a very complex procedure.
We will give you your firstborn back later.
Maybe. And so I'm just, that took me 3 months, let alone getting a dog in the operating room. I can't even imagine.
So I don't actually know what the exact timeline is, and interrupt me if you do, but the way that he was speaking, it sounded like there was at least some amount of lead time, because he described having a lot of conversations. It was not a morning of sort of thing.
It's one of those things we'll have Alexandra talk to him again.
I can ask him.
And you'll tweet it out on Medx Dogs.
Yes, I will. I'll do it. I can check that with him. I mean, I will say that I think that it was not an enormous amount of time, and honestly, I think this is an instance where he was able to get it done because of who he was, and because he just was going to make it happen.
I mean, I'm impressed. So.
Yeah.
And I think the other thing is, and we've spoken amongst ourselves about this, is instigating these sorts of things at a children's hospital
I was just going to say that.
probably has fewer barriers than
Yeah.
implementing it at an adult hospital.
And he agreed on that. He said that's something we
Yeah.
discussed, which is a little bit sad, but I think it's true.
And I don't know if he got permission from everyone.
I was getting hints.
It might have been, I
see
asked
that.
for forgiveness instead of permission.
Yeah, there you go.
That's
But he
great.
definitely had everyone on board who was going to be there and see it. And what this slide actually is about is that the way that the way that he answered my question about was there any pushback, he said, oh, well, actually, we turned this into a great, marketing opportunity because all of a sudden they were able, the hospital was able to write about this great new initiative that an anesthesiologist had used to make this patient so calm. And do not quote me, do not do these things without, having the right permissions. But it was really interesting that was how he put it. And I think he did allude to the fact that his hospital in particular was supportive, and that might be very different from place to place.
I would say this operation. The way I got to know him is through a dear friend of mine who was a very pioneering veterinary anesthesiologist at Pemvet. And we get along partly because it's a little bit of do it first and get in trouble later. And he's friends with Alan Schwartz. So there can be, you know what I mean? Sometimes you have to do it, and it's like, and then you know how to play the PR. So I get the feeling from Alan Schwartz. They both call it Alan, certainly. They've been friends for a long time. So when you're a pioneer, sometimes you use a little bit of that, and I think that's what he did.
And I think CHOP also is very innovative.
CHOP is they have one of the premier
being a leader and a first
in the world.
And
CHOP as for Pemvet, and as we were, that's exactly. And so there's always that element of just wiggle your way through and make it work, and then it's great PR. Look, how do you love this? So you don't want to do something bad, but when you know it's good, when it's in the best interest of the patient, it's a little bit of being a pioneer, and it's like you're always doing it for the patient. But if you don't bend the rules, sometimes you never innovate, because it's the administration who are like, you never get anything done.
Which is part of the culture of just law in America. I don't think that's like administrative pullback as much as like the hospital gets sued.
But that's one of the things, and one of the things about anesthesiology too is it tends to invite creativity and so on. And so I think you have to. You can't break rules and end up getting, with hospitals, but at the same time, you have to know how to navigate through things to make things happen. You know what I'm getting at? And I can see that's why when you have someone's patient, he's that kind of person, and you've got to put the patient first and figure out how to make something happen, because if you're always saying, well, something could work, and so then it doesn't. And that doesn't go against what you're saying of understanding, but it's a way of figuring your way around corners,
Right. Yeah, and we've talked about all the factors that contribute to seniority and experience, and
knowing which rules you can bend is sometimes a trick.
Yes.
And there are lots of myths as well, so you may think that it's a rule, but if you ask, it's actually not written anywhere. It's an assumption.
That's the thing,
and
that's what I meant about the how might we versus we can't. In other words, but he did say communication is so key. It's like if you don't tell people, get upset if you haven't told them. But if you go to them, you communicate and everything, that makes all the difference.
And
sorry, going to interject just a little bit, because as the therapists like to say, our time together is soon coming to an end. So I want to get you guys back on track a little bit, because we've got just some closing wrap-ups. So it's like, and of course we'd be happy to discuss more with you guys, but I just want to be mindful of everybody's time.
So there's it's really important for him to share that story, because once you have an exemplar, the barriers to doing it for the first time, they're changed. Our take-homes for this are, why are we talking about this? Why are we having this conversation? Because really, the absolute number of children who would be helped by being able to bring their service dogs in is probably pretty low, although it's growing. The point we want to make is that these lessons can be applied to different situations. We're not advocating for service dogs being the only way to have a non-pharmacological approach to calming patients. there are studies that have looked at everything from iPads through to clown doctors that have shown, decrease, which I know, I had the same thought. And we won't go into it because Susan's giving me the eye. But I know what you're thinking about clown doctors. I think the important thing is that we really need to advocate in the best interest of the patients. And I think on the next slide there's a really nice quote from Dr. Schwartz, which was, it's a personal preference whether the priority is the patient and the parent or whether the logistics are the priority.
I love Lorax.
Plus the Lorax.
Yeah, I just like that. That's why I was like, we'll put that in there. So anyone, any closing thoughts?
No, just any closing thoughts I'd ask from you guys.
I have one. You guys actually, it's bizarre that I ended up here. It's not necessarily a session that I would have chosen because of just where I'm at with things in my work. But the interesting thing is my 2 sons are blind, right? And my oldest, who's 17, is the most easygoing kid in the world, but he is a perfect candidate for gene therapy if we could get it to work right now. And he said to me that he is too afraid, he's not afraid of anything, he's too afraid of a surgery that involves a needle because they have to go with a needle and he loves dogs. So I'm sitting here thinking, this is Ember at CHOP. Right? That's where our thing is, our doctor is. And I'm thinking, oh my God, and that's who's having the success with gene therapy at CHOP. They actually cured there's a breed of dogs that has this LCA, and they did it at CHOP. Sir Lancelot is the dog that if you look it up, I'll see him.
That's a great name.
So, at any rate, so that's my first aha, is that would be the game changer for Michael.
Well, good.
And then I just had my Mitchell, my second son, who's 13. We were at the ER at Will's Eye in Philly because he's got this black spot in his vision that developed, and they were afraid the retina was detaching. Well, when you have the retinal disease that my kids have, light is so painful, it's like the worst pain you can imagine. But think about an eye exam. They have to dilate and look in with an eye, with a light. So Mitch was trying to be, and I was like bribing with Chick-fil-A. I was, we'll go anywhere you want. But I'm thinking, but he is such a dog lover that if we had a dog on his lap, that would have changed the whole thing. So he has to go back in 3 weeks, and I'm thinking, I'm going to call them and say, can we just, maybe we'll just walk in with the dog, but it's like your work is that important that it just changed my boys' lives. And I'm thinking, all of the kids in our group and in pediatric ophthalmology, this could be a big game changer for them because it is horrific to sit with them and have to go through it. And then, like Mitch, it took him a day to calm down. It's bad enough with the eye drops and everything, and to get through all of that. So eliminating that, it never would have occurred to me had you all not said this.
Well, that's good if they're already, and Doctor, he really does care. He was all excited about this, and he's like, if you want to collaborate, I'll buy you a copy. So get in touch.
I will.
He's semi-retired, but he still sees patients, and he still does that. So.
I'm going to have him meet Jean Bennett. And
and feel free to get in touch, and I can help you facilitate.